is in memory of Debra Beebe, who was tragically killed while working in a group home for persons with mental illness in 1989, about a year after I started as an assistant professor. I just want to say a few words about Debbie before I turn over to Tally, who will introduce our speaker. So after graduating from Indiana University, Debbie came to UW-Madison to get her master's degree in social work, and she was specializing in working with clients with serious mental illness. Back then, the School of Social Work was known as the Mecca for the training in serious mental illness. Marian Tess was here, Mona Wasso, Deb Allness were all in our faculty. David LeCount, who's here tonight, was running the Dane County mental health system. This was the place to come to be. Debbie was in Mona's field unit on serious mental illness. That was the first field unit in the country that focused specifically on people with serious mental illness. And one of Debbie's change projects was finding shelter and food for homeless people in Madison so they would not freeze during the winter. Debbie was known as the little girl coming to the shelter with her big dog. Debbie also worked in a halfway house for Goodwill Industries at that time. The clients and staff loved her. She made special birthday cakes. During Halloween, she would help with costumes and anything else that made the lives of the clients better. On January 6, 1989, a client at the halfway house who hadn't taken his medication stabbed Debbie many times as she came on for her shift. Hearing the screams, another worker called the police as a client ran from the house to a phone booth where he also called the police to tell them what he had done. By the time help arrived, it was too late for Debbie. I think we can all imagine the hurt and pain that family, the Beebe family, must have felt with Debbie's tragic death at the age of 27. And for me, it would have been quite understandable if they turned their grief into calls for the hospitalization of persons with mental illness because they were dangerous. No, but that's not what the family did. Debbie was passionate about working with clients with severe and persistent mental illness and supporting them in their efforts to live in the community. And her family wanted to honor that passion in her career choice. In addition to funding this lecture, which they've been doing since 1991, they've established a scholarship in Debra's honor. The Beebe Scholarship is also made possible through donations from neighbors, extended family, friends, and employers in the South Bend, Indiana community, and contributions from Goodwill Industries, and also many former Beebe Scholarship winners. The scholarship has been awarded every year since 1991 to graduate students in the School of Social Work. By my last count, about 75 scholarships have been given over the years, and these scholarship recipients have literally touched the lives of tens of thousands of persons with serious mental illness and help improve the quality of their lives. This year, 3 students received the award: Alyssa Benson, Katrina Hansen, and Monique Carlin. We congratulate Alyssa, Katrina, and Monique for being selected. I know that Debbie would be very proud of her family and how they have contributed through the scholarship to carry on the work that she hoped so passionately to pursue. I also just wanted to take this occasion to thank Bill Heiss, who's been the assistant director of the school almost since I've been here. For many years, this is on Bill's own accord, he called the Beebe family to invite them here tonight to tell them about the speaker and how the scholarship had made a difference in the lives of our students and what great things former Beebe scholarship recipients were doing. It's been because of Bill's efforts through the years that the Beebe family never wavered in their commitment to funding this lecture and the annual scholarship. We are very grateful to Bill for his many efforts over the years to make sure that the Beebe family knew that Debbie was not forgotten, that her passion and legacy lives on in the School of Social Work. So thank you, Bill. I'm going to now turn it over to Tally, who will introduce our keynote speaker.
What a crowd. Nice to see everybody. It's my pleasure to introduce Dr. Amy Watson, professor from the Jane Addams College of Social Work at the University of Illinois in Chicago, just a couple hours down the road. And she also holds a courtesy appointment in the Department of Crime and Law and Justice. Professor Watson has worked extensively on issues involving the relationship between the criminal justice system and the mental health systems in Chicago and around the country. For the past 2 decades, her research has focused on police encounters with persons with serious mental illness and the crisis intervention team, the CIT model. She has published extensively on this work and presented findings to local, national, and international audiences. Dr. Watson has also conducted research and provided consultation to programs, very involved with programs serving people with mental illnesses with the criminal justice system involvement. These include CIT programs, mental health courts, and prison reentry programs. Recently, she served on the de-escalation work group of the Chicago Police Accountability Task Force and serves on the mayor's mental health steering committee on an ongoing basis. Recently, she served on the compliance team working with the city of Portland, Oregon on issues related to mental health crisis response. Dr. Watson's work has been recognized locally and internationally. In 2008, she received the Young Researcher of the Year Award from NAMI of Greater Chicago, and in 2013, she was the recipient of the Crisis Intervention Team International CIT Researcher of the Year Award early in her career. That's a mouthful, yeah. Dr. Watson worked as a probation officer on a specialized mental health team, which is where the interest originated, I imagine. She has a BA in criminal justice from Aurora University and an AM and PhD from the University of Chicago School of Social Service Administration. Please join me in welcoming Dr. Watson.
Good afternoon. I'm really honored to be asked to do this lecture, and I really thank you to the Beebe family, to the School of Social Work, and to Tally for helping get this set up. I'm going to start by giving just a little bit of overview of what I'm going to talk about. First, a little bit about what I bring to this issue and how I got interested in it, and what informs the work that I do. Then I'm going to talk a little bit about the nature and the context of the problem of people with serious mental illness and encounters with police. Then I'm going to talk about some different work that I've done over the years, starting with looking at how people with serious mental illness experience encounters with police, moving on to look at how officers are thinking about responding to these calls, and then some work that I've been able to do in Chicago, specifically looking at the Crisis Intervention Team program. And there should be a little bit of time for some discussion and questions as well. So first, as Tally indicated, I was a probation officer in DuPage County, and I worked on a specialist mental health team, and that was actually my second criminal justice job. Briefly before that, I worked as a corrections residence counselor for the Illinois Department of Corrections. But while I was at probation, I had a lot of clients that were young. Usually they're young male clients that were early in their illness, and it seemed like every time they were anywhere near a police officer, something bad happened. They ended up with a new charge, they got into a scuffle, they got a new case, then they had a court date, they missed their court date, they got a warrant, and they saw another police officer. So it was a cycle that was really not productive and sometimes quite dangerous for everybody involved. I also got a case with a young man who was approached by a police officer, and he clocked the officer at the side of the head and knocked him unconscious. That officer came and talked to me, and when he came in, he made it really clear he wasn't there to tell me to be really tough on this client. He just wanted me to hear what he experienced. And that really got me thinking that there's so much that we needed to do to really figure out how these interactions can go better. Actually, preferably how we can prevent some of these interactions, but when they do happen, to make sure that they go better for everybody involved. So that's really where that interest grew out of. Briefly, after I left probation, while I was finishing my MSW, I did some work on death penalty cases as a mitigation specialist before then entering the doctoral program, and I had a great opportunity as part of the NIMH Mental Health Services Research Fellowship, and that provided some great opportunities for me to get some training. And during that period, I also met Pat Corrigan, who's one of the leading researchers on mental illness stigma. So he actually hired me when he got a grant to do the Chicago Consortium for Stigma Research, which was an NIMH-funded center looking at mental illness stigma and ways of reducing it. So that was a great opportunity, and I was able to start segueing into some of my interests in criminal justice interactions and stigma of mental illness, and that sort of set me up. So when I got to Jane Addams in a faculty position to really start building a program of research in this area. The other thing that I don't always talk about professionally, but I do identify as a person with lived experience of mental illness, and that's something that I've written about, but I waited till I had tenure to do that. And also, the older I get, I get better at acknowledging how much that informs my work, but also in terms of the more accomplishments that I have, the less risk that when I disclose that suddenly becomes the lens that everybody views me through. I've only had a few experiences like that, fortunately. So, just to start with a little bit of an overview of the nature and context of the problem. We don't have great data on how many interactions police are having with people with mental illness, because many police interactions with people aren't documented at all, but when they are documented, there's not necessarily an indicator that this was a call that involved a mental health issue. There are some dispatch codes that indicate that, but sometimes that's a misapplication of the code, or sometimes that element of a call is not known in advance. So we don't have great data, but our best estimates are that 6 to 10% of all police contacts with the public involve someone with a serious mental illness. That doesn't necessarily mean it's a mental health crisis call. The other thing that we have some good ideas of is that almost a third of people with serious mental illness have some contact with police on their way into receiving mental health services. And actually that percentage is higher in the US than it is in other countries. And I have some guesses on why that might be, where people may have better access to insurance coverage and care. But we know a lot of people, that's their entry point. Again, something else we don't have great data on, but the best data available suggests that at least 1 in 4 people that are shot and killed by police have a serious mental illness. It's probably higher, and now we're starting to look at documenting police shootings so that we'll have better data in the coming years. So people are having a lot of contact, and sometimes these contacts are going really tragically badly. We also know that many people with mental illness are arrested and booked into jail every year, with over 1 million people actually booked into jail. And once people with mental illness are in, they end up staying longer. It's harder to get out. We know that someone who's booked into jail and if they have a mental illness, they may be less likely to get an I bond or to get a bond they can afford to get out. So they may serve more time pre-trial. They also, if they're serving a sentence, are less likely to get credit for time served. They may have more infractions that prevent them from accumulating good time, or the fact that they have a serious mental illness may exclude them from some programs that would allow them to get good time. We also know that in prison, they tend to be more likely to serve their full sentence than someone without a serious mental illness. And when they're on community supervision, they're more likely to be revoked based on technical violations. So when we're looking at this idea that we know that the people with mental illness are overrepresented in our jails and prisons, part of it is we probably have too many people. We have people coming in at higher rates, but then once they're in, it takes longer for them to get out. So what we know about the prevalence of serious mental illness in jails and prisons, and again, the data that we have, people use different measures, different definitions, but somewhere around 17% of the jail and prison population in this country has a serious mental illness. Percentage is higher for women, a little bit lower for men. We also know that in that group, almost 3/4 also have a co-occurring substance use disorder. And when I worked at probation, I actually thought everybody with a serious mental illness had a substance use disorder because all of my clients did. And that was what got them into the criminal justice system. So oftentimes a mental illness alone isn't as much of a risk factor as actually combining it with a substance abuse disorder. We also know that our largest mental health hospitals are jails. Cook County Jail and LA County Jail are the two largest single-site psychiatric hospitals, and I believe LA County just announced they're building a mental health jail with about 3,800 beds, which, to their credit, they're trying to provide a better setting to provide care for the people that are in their custody, but I think we've learned a few things about the usefulness of building large congregate facilities to house people with serious mental illness. I hope we can find a better solution to address that issue. Again, we know that many people are going into jail, and once they're in, they stay longer. So, in that context, as I got to start my own program of research, my first question from looking at the literature just on the police part, because if you look through the literature, you started to see sort of a growing number of articles looking at how police officers think about these calls and what their experience is when they respond to people with mental illness. But at the time, I couldn't find anything that looked at the experiences of the person with mental illness in an encounter with police. So I really wanted to do something that looked at how people experience these interactions with police officers, and then what is it about how police officers treat them that might be more likely to get a good outcome or a bad outcome. So we could learn something that might help us improve how police officers are able to interact with people. At that same time, there was starting to be a growth in the literature looking at the procedural justice framework, and a lot of this work was from Tom Tyler at NYU, looking at procedural justice, and he's done a lot of work looking at procedural justice in police encounters with the general public. A lot of his stuff is looked at people that have been pulled over, but the idea is that when people have an interaction with an authority figure, they pay a lot of attention to how they're treated by that authority figure, and that's more important than getting the outcome that they wanted. So if you get pulled over by a police officer, if they treat you really, really well and respectfully, you might be more satisfied with that, even if you get the ticket, than the officer that treated you in a way that you feel was really disrespectful, but you didn't get the ticket. So if looking at that, really what Tyler's work talked about is how that subjective experience is more important than the outcome. And the key components of procedural justice are the person having voice or participation in the process. So whoever the authority is gives the person the opportunity to say, this is my side of the story. And then, of course, the authority person actually genuinely listens to that, that they're treated with dignity and respect. And the person feels that the person in authority is really concerned about their well-being and is actually considering that. And if people are treated with procedural justice, they tend to feel less coerced, so they feel like they have a little bit more choice and control in the situation. And that tends to also be associated with having views of police as being more legitimate authorities. So Tyler and Blader go on to talk about why this really matters. And first of all, they talk about how identity is what links us to groups. And we make our identity relevant assessments based on how people treat us. So if we are treated by an authority in a really respectful and dignified way, that sort of strengthens our connection to that group. So if an authority representing sort of society treats us well, we may feel more connected to society, and we also may be more likely to follow the norms of that society. So we may be less likely to break the law just because we feel connected to a system that developed those those laws. And this, they talk about may be particularly important for people that occupy marginalized or vulnerable statuses. They're really going to be looking to that authority figure for signals about how safe they are in that interaction and how respected they are, because they are vulnerable. So clearly, procedural justice is actually important to anybody, but it may be particularly important to people that are particularly vulnerable in a police encounter. So kind of bringing that into thinking about police encounters with people with mental illness, I was thinking that how an officer treats a person may be more important than the specific outcome of the interaction, and it may influence the amount of cooperation on a part of the person with mental illness. This could also pay forward and impact future contacts with the police. So if you have a really bad interaction, the next time you're in crisis and the police show up, that's not going to be particularly helpful. So I was able to get some funding from NIMH, and I worked with a colleague of mine, Beth Angel, who's now at VCU, and we were able to implement a study where we looked at the experiences of people with mental illness in these encounters, and it was a two-part study where we started by doing qualitative interviews with folks that had had police contacts, and then we used that data. We wrote that up, and it's probably the most interesting article I ever wrote because it actually has people's stories in it. Even my kids have read it. And then we used that data to develop a measure so then we could interview a larger sample of people and look at the relationship between their perceptions of how they were treated and the extent to which they cooperated. So we did interviews with 20 people that were receiving services at a psychosocial rehab program in Chicago at Thresholds, which is our largest provider. And they had to have had a police contact within the past 12 months, and many of them had multiple. And we did interviews, and one of the most important themes that came out of there is that everybody told us that they felt really vulnerable, and it was a really difficult and negative experience. They expected, even if they were treated well in what the encounter they told us about, they also talked about how they had expected to be treated badly. And this quote I really like is, because they could have took me to jail and killed me, I was scared enough to think that. So that's what people may be feeling when they're having an interaction with a police officer, which I think is something that's really important for the officers to know too, is that they need to do everything they can to help that person feel safe if that interaction is going to go well and get to the resolution that's needed. So we also wanted to look at what were the sort of themes that came out for people that talked about having positive experiences versus those that had negative experiences. And in terms of positive themes, people talked about, it was great. They didn't beat me up like I expected, which is kind of a low bar, but but we also had people talking about officers that were actually kind to them and that seemed that they really cared. So this is a quote from a man who talked about the officer, he and the officer had a cigarette, and the officer shared some low-level personal information that he had an Italian last name, but he wasn't Italian. And really, the man felt that the officer was concerned about his well-being, and he didn't want to go to the hospital, but the officer explained to him that, well, we're concerned about you, and he actually went voluntarily. So I thought that was a really great example. We also had people talking about just like, the officer heard me out, they heard the other person out, and I felt like they were being fair, and that was good. Or other people talking about, well, the officer was just doing his job. So these were the things that were associated with interactions that they felt okay about. And we had one woman who told us about an interaction where she was arrested, and she acknowledged she was breaking the law, she needed to be arrested, but the officer was so nice to her, it was a really good experience. But then she talked about another interaction where she wasn't arrested, but the officer was so rude that she was really upset about it, and she remembered that. So again, really underlining it's really important how people are treated, particularly when they're feeling that vulnerable. So in terms of looking at the negative experiences, a couple of things came up of people that have had negative experiences. And one of the things I want to be really clear is people talked about multiple experiences, and the same person could have talked about a really positive one and a really negative one. And I had a reviewer at the grant that said, well, how are you going to make sure that you get any positive examples? People will only want to talk about negative examples. Well, that wasn't true. We didn't have to, we had a system set up if that happened, but it didn't happen. But one man, and I did this interview, and I remember talking to him, his landlord called the police on him because he was suicidal, and the landlord was worried. And when the police got there, he was sitting on his couch in his, a t-shirt and his underwear, and the police came in with their guns drawn, and they were yelling commands at him, and all of a sudden, they were on top of him. And he talked about being really scared and having difficulty processing the commands they were giving him. So he couldn't respond as fast as they expected him to. He was a large man from thinking about what a police officer might be thinking. There could have been a gun in the couch, I guess. So they were coming in, but he just could not process the commands as fast as they needed him to do. And it was really scary for him. Fortunately, nobody was hurt. Other people talked about officers using unnecessary force and being unnecessarily abusive. And this quote, a man got really angry, and he's like, "Oh, it made me angry, and it made me want to get his gun and shoot him." So just feeling so vulnerable and thinking that through. Another one is just a man that felt like the officers were disrespectful to him in the questions they were asking while they were sitting at the hospital emergency room waiting to hand over custody. He just felt sort of belittled and demeaned and diminished. And then finally, people talked about situations where they didn't have any opportunity for voice, so nobody would listen to me, and that was a really negative experience. So a lot of these themes were very consistent with procedural justice, and I think these have been really useful as I go out and talk to police officers too. If you tell them, well, you need to treat people better, it's like, okay, what does that mean? What is it that's useful? How do you actually break that down into something we can actually take and do in what might be a really intense situation? So that's been useful. So the next piece of the study is we developed a measure. We used some existing measures and adapted them, and we used information that we got from the interviews so that we could measure different characteristics of calls, perceived procedural justice and coercion, and a number of other variables so that we could develop an interview guide, a survey that we could collect information from a larger sample of people. And we did cognitive testing and revision, so it was several stages. And we ended up then recruiting 154 people that were receiving services at a couple different thresholds locations. And one of the things that, I like this slide, and I'll explain to you why, it's kind of busy, but one of the things that was really apparent was that people are having contact with police for a lot of different types of reasons. That for this group, only about 5% of the calls that they told us about were mental health crisis calls. The largest category was nuisance and street stops, ID checks, those types of things. Some of that is a function of where we recruited. These were people that were receiving psychosocial rehab services in an urban setting. Many folks didn't have that much to do during the day, so they were out in spaces that people didn't want to see them and that police stopped them and asked them a lot of questions. But I just remember being really shocked I'm like, I've never been stopped by a police officer and asked to show ID. Which you're supposed to do it if they ask you. I also didn't know at the time that having alcohol out on the street was illegal either, but I don't typically walk down the street with a beer in my hand either. But they just reported regular contact that felt sort of harassing. We had, about 6.5% of the calls were domestic disturbances, so police were called to a home, about 24% non-domestic law violations, and then a large group of people that the contact was the result of them being a victim of a crime or requesting some type of assistance. So it's a pretty broad range, and that's something we're finding in some current work we're doing too, is that there's a lot of these sort of gray zone interactions that don't require arrest, don't require a transport, but they're opportunities, one, for a good interaction, but two, sometimes to link people with things that might be useful to prevent a subsequent interaction. We also looked at just the outcomes of the calls, and again, all of the mental health crisis calls were a trip to the hospital, and about a quarter of the calls were arrests. Many of them, there was no action taken. About a quarter, there was some assistance provided. Again, I just like this because it really illustrates that people are having a lot of contact besides just while they're in crisis. So we looked at the data from our procedural justice measures, and what we found is that people that had felt that they were treated more consistently with procedural justice felt less coerced and pressured in the encounter. They reported greater cooperation, less resistance, and struggle with the officer. So this is a really key thing that actually if we can help officers treat people more consistently with procedural justice, that makes everybody safer. Because people may be more likely to cooperate because they feel safe and secure in doing so. It was also associated with higher perceptions of police legitimacy. And when we ran models, we looked at it, the impact of perceived procedural justice was strongest in the situations where the person was most vulnerable. So they were their arrest or transport to hospital situations where the person was most vulnerable. We included a measure, Bruce Link's measure of perceived devaluation and discrimination, which is just a measure of their perceptions of public stigma, not stigma in the police encounter. And we found the people that perceived really high public stigma, procedural justice didn't have as much influence on cooperation. They cooperated, but it wasn't associated with that. So they may have been cooperating just out of fear or other reasons, but for the people that were lower or moderate on perceived stigma, there was then an impact there. So takeaways from that study was in interactions with police, people feel really scared and vulnerable, and they pay attention to how police treat them, and it really matters. And there's some things that we can really try to support happening that will make everybody safer. And I love this quote. As we were wrapping up this study, Chicago was starting to implement their CIT program, and this man had heard about it and was actually felt very positive about it. So moving on to the next project that I had a great opportunity through Nancy Wolf's Center at Rutgers to do a project with Jeff Drain. And what we decided to do is to look at how police officers actually think about these calls. And so we were able to recruit officers in Philadelphia and Chicago to look at that. And what we did is we used schema theory. So schema are basically cognitive structures that people use to organize information, and they allow you to use cognitive shortcuts to kind of about certain situations and how you respond. And we all use it, they're necessary. Sometimes they actually support bias, which isn't good, but that's the way our brains work. We have to use them. So we wanted to look at what are the schema that officers have of these types of calls. So we did a study that had two phases. The first one was qualitative interviews with officers just to ask them about, okay, what's a typical mental health related call? What is it like? What would the people be like? What would happen? What would you do? And we asked them about different types of calls. And then what we did was we developed 4 sort of very brief scenarios that we asked them then to rate the characteristics of to see if we could sort of capture what their schema might be. And that we actually administered to 147 officers. Some were probationary officers, so inexperienced officers. Some were more experienced officers, some were CIT in both cities because we thought that maybe experience level might impact stigma. So we had 4 of these scenarios. One was a call to a home about an adult in crisis. One was a call to a home about a juvenile, a street disturbance, and then a repeat caller. And after each blurb, we had officers go through it and rate them. And I'm not going to go into too much detail on this except for to give you the punchline. But here we did latent class analysis just to see if there were these different sort of groupings of characteristics to capture those schema. So here, the call to the home for an adult. So imagine you have a call to a home where someone reports their adult family member is causing a disturbance. You have reason to believe the person has a mental illness. So we had officers rate all these different characteristics, and it turns out that our latent class models, a 2-category solution fit best. Group 1 was officers that were thinking about a call where the subject was cooperative, was on meds, and was older. Group 2 was the subject was resistant, was using drugs, and was younger. And of course, we didn't find a lot that was significant in terms of the officer experience predicting which group, but we did find is that the officers that were into the group 2 were more likely to say they would have had to go hands-on, which with a resistant subject makes sense. We had a similar pattern when the call was to a home about a juvenile. 2 groups, again, is level of cooperation or resistance and the presence of drugs were what seemed to drive the differences between the 2 groups, with the more resistant subject that was also using drugs being the one that they said they might need to go hands-on for. The street disturbance, again, was a 2-group solution with the same sort of breakdown. And this was just you respond to a situation with an adult causing a disturbance, and you have reason to believe the person has a mental illness. The repeat caller was the one that was different, that the best solution there was 3 categories. And this is a call to an adult that reports a crime. The police are familiar with this person and believes that the person has mental illness. So you had group 1, which is a younger male that's threatening and using drugs. That person they're more likely to go hands-on with. Group 2 was cooperative, less likely to be using drugs, and there was family present. And then group 3 was someone who was older, alone, and cooperative. So it sort of broke down into 3 different sort of subtypes for this call. But again, with the person that was more threatening or less cooperative and using drugs being the one that they thought was more dangerous. So kind of the take-homes on this is that officers do vary in their schema. And there was some difference. Some of the older officers and female officers were more likely to fall into the cooperative group, where the younger officers oftentimes were more likely to think of the more dangerous ones. So it's interesting to kind of pick apart what might be going on there. But the factors that really differentiated was resistance and cooperation, presence of drugs, sometimes visible signs of symptoms, and subject age. Sometimes the schema group predicted outcomes. Actually, the outcome was only in scenario D, but we didn't find much for officer experience level. Part of it was we might have been underpowered. But again, why I think this is interesting, and it's not really a surprise that police officers think about calls in terms of the risk and danger involved. That's how they're trained. But this helps me think about, as we start talking about thinking of different responses we could send to some of these calls, what are the calls that we could send just a team of mental health providers to versus the calls that need a police officer? So it sort of, for me, it helps me start thinking through that and how we might actually have those conversations. So after we finished up that study, the Chicago Police Department was beginning to implement the Crisis Intervention Team program. And I had been hanging around meetings long enough that I knew the right people to talk to get a letter of support from them, so I was able to get some funding. And I'm not sure if everybody here is familiar with the CIT model. Actually, above the slide, the white paper, that's the Crisis Intervention Team core elements. If people are interested in it, you just Google that and you'll find it, but it spells out the different elements of the model, which has a lot more elements than just the training piece. The challenge coin that's up there is from Wisconsin, and the picture is a recently graduated group of Wisconsin police officers from a CIT program. So I tried to at least, not be Illinois-centric. But so the model, most people know about CIT training as a 40-hour training that goes through signs and symptoms of mental illness, de-escalation skills. It also includes visits to community mental health providers so officers can become familiar with resources, panels with family members and people with lived experience so officers have the opportunity to interact with people in a non-crisis situation. Because typically they only see people when they're at their worst, family members and persons with mental illness alike. So there's that piece of it, but really the most important piece of the model is the partnerships between law enforcement, community mental health providers, families, NAMI groups, people with lived experience. And that's really what the team is. It's not like a roving group of police officers that go out. The team is really this collaboration, and that's something that's really important so that as officers take on this role and are responding to these calls, they have things set in place so that they can connect people to the right services and hopefully preventing the next police encounter. Another piece of it is having easy entry into emergency psychiatric services. And when the model was first developed, everybody was talking about we just need to get officers to take people to the ED. Well, now everybody's saying we just need to get officers to take people to someplace besides the ED because it's not a great place for someone in crisis. And fortunately, we are starting to see these other options start to be built. But the idea is that there's some place that police officers can hand a person off to that's not jail that will actually then respond to the person's mental health needs. What we're really seeing with CIT programs too is because in many places all we had was EDs, is these partnerships are starting to work to build a broader system of care. So we're seeing pushes where there are mobile crisis teams to get triage centers, to get other resources in place because we realize that we train police officers to do something and it's still not a good solution. There's also changes in policies and procedures that go into place, and oftentimes with CIT programs, you see a lot of partnerships with NAMI groups so that there's recognition of the work that officers and mental health providers and NAMI group members are doing, so that it sort of is reinforced going on, and that helps sustain programs, because that's been a big issue. It's been a big issue in Chicago in terms of our program, and I've seen it a lot of other places. So that's sort of the model. The one thing I like to say is when people call crisis intervention training and they call it CIT, the T is actually the team part. Training is part of the model. And we have some research on CIT, but most of the research is actually just looking at the training. And I've been guilty of that too, because it's the easiest piece to look at in a study. But we have a number of studies using non-experimental or quasi-experimental designs that support CIT training is effective for improving officers' knowledge, attitudes, their confidence in responding to calls, and as well as their de-escalation preferences, so the value that they put on using de-escalation. What we found is those effects are more robust for more experienced officers. So one of the pieces of the model, the CIT model, the original model was that officers become CIT officers. One, they volunteer and they're vetted. So you have officers that want to do this. They're probably already pretty good at it, but they want some more tools. But they have to be experienced officers that already sort of have their experience in being safe as a police officer on the street. So you're adding a set of skills that someone then can move back and forth between the different skills that they have as a police officer. But it's really helpful if it's an experienced officer. They're better able to do that. So, and that's just one study, and it's something that, we've been trying to look at, but again, it's very difficult. It's also really difficult to get police departments to do everything a researcher wants them to do. So, we have other research that's also looked at the impact of CIT training on call resolutions and use of force in encounters, and we have evidence that CIT trained officers are more likely to link people to services than non-CIT officers, and also some studies have found a reduction in arrests. It depends on the jurisdiction, and that gets a little bit complicated, but we have strong evidence that it increases linkages to services and that CIT officers use less force with more resistant subjects. So there seems to be a safety effect too. And it's a little bit tougher to look at because use of force is a very low frequency event. Even though when it happens, we hear about it, and the consequences can be really horrible. The other thing is Michael Compton, actually one of his studies recently looked at that the effect of CIT training is more robust for people that volunteered to become CIT officers as opposed to officers that went through the training as mandated. So some support for that part of the model. A few studies have looked at pre and post CIT implementation. And what they have found is that following implementing a CIT program, so not just looking at the training, more mental health calls were actually identified at the 911 level, and there was increased transports to mental health treatment and the proportion of those transports that were voluntary. And that's from Akron, Ohio. A more recent study that was done in Michigan by Cheryl Kubiak and her colleagues found that after they implemented CIT, they showed a greater rate of transports to their crisis triage center. So more officers were taking steps to get people to care. So now I'm going to shift and talk a little bit about CIT in Chicago, which is where I've done my work. And that it started in around 2004, 2005, we had a series of police shootings of people with mental illness, and Sun-Times columnist did a story that started like, because one person had a butter knife, one person had a fork, and so he said, all we need is a spoon and we'll have a full play setting. I guess it was embarrassing to the mayor, and the mayor's like, okay, we're gonna do this, which the people that had been working on trying to get it to happen for a long time were like, okay, we'll take this window of opportunity. But they decided to implement CIT in 2 pilot districts, one on the north side of the city where it's pretty rich in mental health services. I would say there's not enough, but there's more than anywhere else in the city. And one on the south side where there really weren't many services, but they knew they had a lot of transports to the emergency room for psychiatric assessment. And they trained 30 to 40 officers in each district, and it went really well. So anecdotally, people really liked it, so they decided to take it citywide. At the time, it was 25 districts. Now we have 22. And so by the fall of 2015, while I was collecting data for my most recent study, we had about 2,300 CIT trained officers in the city out of about 13,000 sworn. That's increasing now. I'm sure people have seen the news. We're under a lot of pressure to reinvest in our CIT program. They did mental health crisis response and CIT directives, and they also did work with having designated emergency room drop-offs where officers could bring people. They were guaranteed priority, and so they could get back out on the street, and it was also guaranteed that the person would be assessed. That worked well in most of the drop-offs, not all of them. And that was something that the central CIT unit really worked hard to keep addressing when there were issues. So the first study that I was able to do with Chicago's CIT program, I got R34 funding from NIMH, and we were able to look at the 2 pilot districts, and then for each of the pilots, we did a neighboring district that was very similar demographically, but they didn't have as many CIT officers and weren't as far along in implementing. And there we were able to then, what we had to do is we had to interview officers about the calls they went on because the administrative data wasn't useful. And what we found is that the CIT trained officers, they directed 18% more of the mental health call subjects to services than the non-CIT officers. So we saw that. We saw that the linkage was more likely in the 2 districts on the side of the city with more services, go figure. On the south side of the city, one of the things that I heard that was that we didn't hear as much on the north side is that people were walking into the district station saying, I need to go to the hospital. So that's where people were turning. Where on the north side, a lot of people were already in some way connected to care, although somewhat disconnected, but they had other people to call if they needed to go. In that study, we also found that the CIT officers were using less force with more resistant subjects. So we saw some beginning evidence of that safety impact. So after that study, and so I used that to get more funding from NIMH. And so the next project I put together, and I was able to work with a number of great colleagues, Michael Compton, Jeff Train, Jen Wood, Joe Kaplan, a whole list of people that were really helpful. And we designed a study where we looked at mental health calls across all 22 Chicago police districts. So our aims of the study were really to look at the impact of CIT training. And I guess one of the things that was really good for me as a researcher, really bad for everybody else, is that we weren't dispatching CIT officers to mental health calls. So our call takers might get a mental health call, but they had no idea who was CIT trained. So they weren't, so it was kind of random of who got the mental health call. So that way I could compare calls handled by CIT officers and calls handled by non-CIT officers. Not perfect randomization, but it was at least gave me some comparison. And so what we wanted to do is look at the impact of having a CIT trained officer or just a regular officer. We wanted to look at that impact on immediate call outcomes, but then also look at how that was different across the city with different levels of access to services. So we're looking at, where you are in the city, how does that matter on what the calls look like, but then also what the outcomes are. We also were able to recruit about a quarter of the call subjects, so we could look at kind of how they experienced the calls and then how they did over the next year. And we're doing some mapping as well as looking at where calls occurred. And so this is just a map of the city of Chicago, and the red lines are the district boundaries. There's 22 districts. The little yellow houses are mental health service providers, and we mapped that about 2013 as we were just getting started going. And then the green push pins are drop-offs for people under 18. The blue push pins are the adult drop-offs, so they're emergency rooms that have the agreement. So the big thing to notice is that our services are not particularly evenly distributed throughout the city. So where you are matters. The north side has a much higher number of services. The south side is pretty sparse. And also during this period, we closed 6 of 12 of the city mental health clinics as well, and many of those closed were in the areas that have the fewest yellow houses. So we have some big disparities. For what we did, again, we weren't able to use administrative data to look at mental health calls, so we spent quite a bit of time out in the police districts. We went to each district and spent at least 6 weeks there. We addressed roll calls on every watch and told the officers what we were doing, and we invited them, when they came back from their watch, that if they had had a mental health call, to do an interview with us. So the data that I have isn't necessarily representative of all mental health calls that were occurring. It's all the calls that officers were willing to tell us about, and we couldn't mandate that they went. And what we found is that, the first few days we were there, people didn't talk to us. We had to be there for a while. We brought food all the time, and then they started talking to us. So I never brought donuts because that would be offensive, but we brought food. So we collected data on calls. We also did ride-alongs on all watches in all of the districts, and we selected a subsample of officers for qualitative interviews. We mapped where services are, where the calls were occurring, as well as some community characteristics. For the call subject, we were able to recruit, again, about a quarter of the call subjects. We did interviews about their experiences of the encounter, and if we did the mini, so if they met criteria for serious mental illness, we invited them to the longitudinal arm and followed them for a year. And we had pretty good retention. There was maybe like 5 or 6 people that didn't meet criteria, and out of the people that did enter the longitudinal arm, we didn't lose too many people over time. We paid them $50 for each interview, which helped, and we met them wherever they wanted us to meet, so that was really helpful. We did some qualitative interviews there too. So, for the data that we collected between July of 2013 and September of 2016, we had 300 officers that participated. A little over a quarter were CIT trained. They told us about 428 mental health calls. Again, about a third of them were calls that had a CIT response. About 65% were dispatch initiated. The rest were on view, that the officers just saw something and intervened. About a quarter of them were dispatched as a mental disturbance call. So 3/4 of them were not dispatched as mental health related calls. And one of the things we looked at is about a third of them were subjects that the officers were, the officer we talked to was actually familiar with that person. Just looking at the characteristics of the officers that participated, they kind of reflect the demographics of the Chicago Police Department. Majority male, white. 90% of the ones we interviewed were police officers. We had a couple field training officers and sergeants that also participated. In terms of the call subjects, 65% male, 65% African American, a little over 11% Latino. We asked officers the different sort of signs that are things that they recognized, and officers indicated that about 80% thought the person had a serious mental illness. And I guess I should back up briefly and say what we told officers, we want to hear about calls where you believe the person has a mental illness, either because of information that someone gives you, the way it was dispatched, or things that you observed. And that's how we defined it. And I've had long conversations with people about, like, we should be more specific about how we defined it, but it always gets us into trouble. So it's really difficult. So we go with, does the officer think the person has a mental illness? And they're actually pretty good. They might not be able to tell you exactly what it is, but they know that they're responding to someone who's having some type of difficulty. Also, about a third they thought had an alcohol problem, a quarter a drug problem, and a little over 20% had an intellectual or developmental disability. And this is something that we're going to pull out and start to look at, because there's no literature on police response to people with intellectual disabilities, really, at least not much current from the US. There's more from other countries. We looked at call locations. So about half of the calls were calls to people's homes or to housing. The next largest category were just to a business, a government facility, or transit, and then some a small group that were hospitals or mental health providers, and it was interesting. If it was at a mental health provider, the provider wanted the person to go to the hospital. If it was at a hospital, the hospital wanted the person removed. So, and then just a few that were street or in the park. In terms of call outcomes, so the largest group was taken to treatment or referred to treatment. It's clear up here. So the largest one was transport to the emergency room, followed by resolve on scene. Just a small portion, just 26 or 6% of the calls were resolved with arrest, which makes it a little bit difficult then to do analysis and run models looking at outcomes of arrest, but it was just a very small portion. Some other descriptive findings related to the call outcomes is that more than half the encounters didn't require taking the individual into custody for any reason, so for arrest or transport to the hospital. Informal resolutions were really common, and we got a little bit of information on what they did. So rides to transit, to home, releasing the subject to a family member, so they tried to do some troubleshooting on, how do we resolve this so the person's safe. We had officers that gave someone a couple bucks so they could get their prescription filled. Officer that told us about a man that was very agitated and upset because someone stole his coffee, so the officer bought him a cup of coffee. Another officer that convinced a woman to go get her hair cut just to separate her from her mother because there was too much tension. So they do a lot of problem solving there. Just over half the encounters, there was someone on scene that requested a specific outcome. Most often it was a family member, and most often the request was a transport to the emergency room. And in the 402 calls where no arrest was made, 32% of the officers said that they could have arrested. So I call those the true diversion from arrest. Sometimes people count anything that's not an arrest as a diversion from arrest. It might be some type of diversion, but most police work doesn't involve arresting people. So, but these were the ones, and it was anywhere from some minor charges to, more serious charges. And of those calls that they could have arrested but didn't, about half of those were transported to the hospital. The other resolutions were some type of informal resolution. So one of the things we needed to do, because we were testing CIT, although I have to acknowledge that this is not a perfect test of the CIT model, because during the period that we collected data, the CIT program in Chicago was severely under-resourced. It was hanging on by a thread. So we had CIT trained officers, but they didn't have the support that a fully functioning CIT program would have. But we wanted to look at the impact of CIT on call outcomes. So we had to collapse the outcomes to arrest, linkage to services, and informal resolution. And we ran multi-level logistic regression for each of the outcomes. And we included call location type, whether or not it was dispatched as a mental health call, whether they had a CIT response, and then some officer characteristics, and we included district in the models as well, because they were all clustered into the districts, and we looked at district disadvantage. So just looking at the outcomes that we have, so CIT was only significant as a predictor of linkage to services. So calls that got a CIT response had an odds ratio of 1.66, so they were more likely to have a linkage to services. Whether or not the call was initially dispatched as a mental health call was actually a predictor for all of the outcomes. So if it was dispatched as a mental health call, it was less likely to be resolved as an arrest, more likely to be resolved with linkage, and less likely to be resolved with an informal resolution. So this is actually pretty similar to what we found in the earlier study with the 4 districts, is our primary effect for CIT was on increasing linkages to services, either a transport to the hospital or some type of connection to care. We're still looking at some of the force data, and one of the things that I've seen in this study, but also in some other studies, is the problem is if you have an officer that's taking someone to the hospital, you're increasing the likelihood that there's going to at least be a low level of force. So trying to control for outcome to see how that predicts force. So we're working with those models, and hopefully we'll be able to get some of that out soon. But really looking at, in terms of the impact of CIT, it's really on this linkage piece. So We have other themes that we're really looking at. We have a ton of qualitative data from ride-along observations and interviews. We also have, when we went to roll calls, we had some really fascinating conversations with officers, and you just get to, when you spend that much time there, they start talking to you. But in terms of looking at some of the themes that are coming out of our qualitative data is that CIT officers and non-CIT officers talk about these things a little bit differently. CIT officers really talk about the importance of having patience and taking some time and kind of slowing things down to resolve a call, where in the non-CIT officers, we more frequently heard things about, at some point it's just on, you just have to resolve it. So we saw that difference. We also saw CIT officers talking more about getting actually resistance from their supervisors and other officers about really what police should be involved in. Where the CIT officers, whether or not this should be a police function or not, we're involved in it and we have a responsibility to do something here. Where non-CIT officers might think this isn't our problem, this really isn't something we should be involved in, we're just gonna leave it. So we saw that difference, and the CIT officers really did talk more about problem solving and figuring out what do I need to do to resolve this in a way that might make it less likely that we're here again very shortly. And I just remember an officer talking about how he transported somebody to the hospital, gave the hospital his cell phone number saying, if you're not gonna keep him, give me a call, I'll come take him to the shelter. So I don't want him just walking out of here and waiting for the next police contact. So we saw more of that with the CIT officers. Other things that came out is something that seemed to be a really common experience among officers is just sort of repeated calls to homes where family members were really having difficulty coping and managing the behavior of their loved one and being very frustrated and sort of overwhelmed. And so this is a quote from, it was a non-CIT officer, but he's like, we're responding to a regular, he's breaking stuff in the house, family called. They didn't take him to the hospital, the family just wanted the police to come and calm their loved one down and help them manage that. And they really talked about doing that a lot, so that people really don't have anybody else to call. And in Chicago, we just got state approval for Medicaid funding for mobile crisis for adults, and that's just getting ramped up. There really isn't anybody else to call, and you have families that are really struggling, and officers are recognizing that this is what we're doing, we're responding to something. Really, there should be another resource. We do it over and over. And this was really quite common. The other thing, we heard from officers is sometimes we'd ask them, but sometimes they'd just start telling us, is what they wish they had. And actually, they have some good ideas. I had one officer that talked about, on the far south side of the city, we really need a NAMI living room here. So that, when families are getting overwhelmed and there's tension, someone can just go hang out. I'm like, wow, she wasn't even a CIT officer. She just, but they want something other than the emergency room. They see that as not being a great place. And this is a quote from an officer that talked about, when they bring people in, the people feel betrayed. And the quote is, like you brought them to the hospital and they're just gonna stick them with needles, strap them to the bed and fill them with medicine, which usually happens. But can we do it in a different way, So he really saw, I don't like what I see, and unfortunately all of our hospitals aren't quite that bad, but some of them are. And I had an argument with the journal editor about this quote. We submitted an article with this quote in it, and the journal editor really wanted me to conclude from this quote that that we should say police officers need more training. And that's not the conclusion that I drew from this quote. My conclusion was we need to look at how we're providing services. And we need to really think about how do we make sure that wherever you are in the city, that we provide the best, most supportive services to someone who's in crisis. So I almost pulled the article, but then I didn't have to make that change, so it went. But the other thing that officers talked about is just needing someone to do follow-up. So if I keep going and seeing this person, or if I'm taking this person to the hospital, they're out and I see them again. One officer talked about having somebody at the police station that did that follow-up. And another officer talked about just having somebody go and do the follow-up and do that. And we do see, there are some CIT programs that have someone that watches, like, oh, are we seeing this person regularly? We have a team that goes out and does that linkage. Also, I know There's different models of doing it, but they really see that we do this temporary solution right here. We need somebody else to pick up the rest of it, and that really needs to be the mental health system. So this is just some preliminary mapping that we did, and the maps are hard to look at. But the first one is a map of CIT calls resolved on scene, and this is done by Joe Kaplan, who's developed this method called risk terrain modeling. And the darker spots are where it's higher risk for that one resolved on scene. And then what it looks like is what are the risk factors? What are the community characteristics where it's more likely that it'll be resolved on scene? And here it was gas stations, grocery stores, and schools. So calls that happen closer to those places tended to be more likely resolved on scene. The other one was calls resolved with transports to the ED. And the community factors that were associated with those are grocery stores again, apartment complexes, mental health care providers, and variety stores. So the apartment complexes and mental health providers kind of make sense according to the rest of our data. So we're still working with that data to see kind of, sometimes it's just helpful to see it in a picture as opposed to some of the other descriptive data that we have. So thinking about the implications of all this and actually going through the process of putting this together actually helped me think about my own work. But we know that in encounters with police, people with mental illness feel really vulnerable. They're scared. We also know that police officers think about these calls in terms of risk too. And Sam Cochran, who is one of the developers of the CIT model, will often talk about this, is we need to address fear, is that everybody's kind of afraid, and that's a recipe for things to go really badly. I mean, officers will not tell you they're scared, but they will tell you they think that these calls is unpredictable. And sometimes they're kind of anxious to get it resolved just because that way the unpredictability is over. So if we can figure out ways of supporting officers, one, and really helping the person that's, if it's a crisis call in particular, feel safer, that's going to make everybody safer. And you know, certainly some elements of procedural justice can be useful, and many of the things that are taught in CIT and other types of de-escalation training could be really useful here. But really, if the officer could figure out a way that helped that person feel more in control, because a person in crisis is already feeling out of control. Now you throw a bunch of people with guns in there, it's not very helpful. So how do we respond in a way that at least doesn't make that worse? And that's going to make everybody safer. In terms of thinking about things more at the macro level, really what we're talking about is that officers are providing temporary solutions to really chronic vulnerability. And oftentimes that is because our other systems aren't adequately resourced to address those. I mean, you know, certainly I know in Chicago, our mental health system is so poorly funded. It's really awful. So we have good providers and we have people that are working really hard, but it's just so bare bones that, you know, officers are really having to pick up the slack. And we know that officers would prefer to shift that responsibility back to mental health, and I think that really is most appropriate. If we don't want to criminalize mental illness, we can't be building our services just on the criminal justice side. Because at this point, I mean, I teach social work students, and they can get jobs, you know, fresh out with their MSW that nobody could live on, doing the hardest work. So they're doing these community mental health jobs, doing the hardest work, for the least pay, and they move on when they can because they need to be able to afford to live. So you constantly have the least experienced, lowest paid people that are working in some of this toughest space. And we really need to shift that so that it's not the police officer who's actually maybe better trained and more experienced and better paid responding. That's my... So that's sort of my editorial thought that I think kind of drives this, is that, yeah, we do need to prepare police officers to do this work and to assist and to provide safe responses when they're needed, but we really need to push things back and resource the mental health system. And, you know, sometimes I feel guilty. I've spent all this time focusing on preparing police officers. It's like, wait, the focus really needs to be back on resourcing the mental health system, because there's really good providers out there, but people can't stay in the field, or it's hard to. And I know when I talk to even Thresholds, one of the providers that I've done a lot of work with, they have troubles hiring people and staffing these programs. And I don't think that's unique to Chicago. I think that's probably pretty common. So we do need to do these partnerships, and I think some of these partnerships can actually really drive that in terms of pushing it. The problem is, one of the things that I see is that we are starting to expand more and more on the criminal justice side. We're building the jails. We're doing more. Some programs have case management run out of police departments, which may be appropriate for a small group of people that are much higher risk. But the problem is, if they're doing that, we might not fund the mental health system to do it for everybody else. So that's the only way to get it. So that's sort of my editorial piece, that what I've drawn from my work so far. So I don't know if people have questions or comments.
So when you talk about the CIT training, there was a stat about 18% that were trained. There was a higher increase in referrals to mental health.
So among the officers that were CIT trained, they were more likely to link people to mental health services. 18% more of the mental health calls they responded to.
All right. So with that, so the CIT training is obviously has to be funded and officers can go through it. Has that trickled down into their like the initial police officer training, like kind of having them have exposure to some of that stuff instead of going the whole CIT route?
I mean, I've seen it in a lot of places. Agencies are beefing up what they provide in the academy, and some agencies are just moving the 40-hour CIT into the academy, and then saying, see, everybody's CIT trained. That's gone really badly in a few places. Because what's happened is you have a group of people that have no experience yet, so they're not absorbing it as much as they would if they're more experienced. And the other thing is that then you're not selecting the people that are best to identify a CIT. So Portland, Oregon did this. They had a CIT program. It was quite strong. It was volunteers. It was a specialist component, but then the program deteriorated a little bit. Bad things happened. The community said, train everybody, and they moved it to the academy, which face value sounds like the best thing to do. But what happened is they lost some of the collaboration pieces, and they also lost the ability to send the officers that should really go to those calls, because they assumed everybody would be equally as good, and it didn't work as well. So making sure that they have something in the academy, something in service, that everybody has that basic floor, but then reserving a role for some specialist role. So different program communities that are doing something other than CIT that seem to have success still have some type of specialist role in there.
Yeah, there was a slide that was talking about the patients versus the just getting on with it. And since you already mentioned that the CIT officers are already more experienced, and then they're probably more confident in their job or their roles, I'm wondering if the getting it on folks are just more worried that they have to respond to so many calls in order to look good performance reviews and those types of things. Like if they're feeling more anxious about their job performance, so they would want to resolve things faster. That is a calculation that you look at.
Certainly, and certainly less experienced officers with less time in are going to be less likely to argue with their sergeant about how much time they're spending on a call too. Where CIT officers, if they're more experienced, at least what I've seen in Chicago, the more time they have in, the more cynical they are and the more they're willing to argue with their sergeants or whoever it is. The other thing we don't do and we need to do is start rewarding some of those things for good performance on calls that aren't resolved quickly but maybe are resolved peacefully. And we need to build that into the performance appraisals, and I don't think we've done that yet.
What skills would you say make officers most successful in dealing with people who have serious mental illnesses when the officers may not have CIT training?
I think some of it is just being able to respond to somebody with compassion and treat them with dignity. I mean, there's nothing that beats, the best thing you can offer somebody in crisis is just to treat them decently. And I think some officers are just naturals at that, and some of them aren't. And some of them can get better at it.
So when you say that the police are picking up some of the areas where social workers or other mental health professionals aren't able to. To me, that sounds like we should probably be investing a little bit less in police and a little bit more in mental health professionals and social workers, because, well, I know at least in Madison, I've gone to the Community Academy program for citizens, and they pride themselves on wearing different hats. One of those being social workers, and they are not social workers. I mean, I don't want a police officer to be a social worker, because as you've just presented, that doesn't always end well.
Right.
And they are authorized to use force when necessary and not have to answer until after the fact. And I can only imagine that if we had the resources that we needed, if we paid social workers and other mental health professionals the way that we do pay police officers, that we'd probably have less of these issues. We'd have more, we'd have better care systems, there'd be less disparities. But I mean, I don't know if you want to comment on this, it's kind of controversial, but like, I can't imagine police services want to have less funding. I can't imagine they're going to willfully give up what they have to provide better for the city.
Well, I think you're right. I mean, everybody wants to hang on to what they have, and I think at some point we need to figure out how to put more in mental health, and maybe some of that, I mean, of course, the idea is that you do that and you're saving money somewhere else down the line, which politically it doesn't always go over that well. But thinking about how we shift that, and if we do this, we're also reducing costs on EMS, emergency rooms, so figuring out how to adjust that. Right now, we're not in a situation where we want to give police less training on mental health, just because it's going to take a while to shift, but I think you're right, and we have to figure out how to make that case of the different places that we will save a lot of money, so that we can put the resources in mental health.
You're kind of for two more.
I read a study a while ago about sort of expanding. I think they're getting like more EMS involved. What about dispatcher training? Can you talk about like what it looks like expanded and where?
Yeah, actually, so there's a lot that's going on right now in terms of, I mean, Chicago finally trained all our dispatchers, so I couldn't do the study the same way now because our dispatchers actually ask mental health questions and they know who the CIT officers are, that type of thing. But we're starting to see a lot of agencies either developing their own 8 or 16-hour dispatch trainings, or there's different groups that are providing it. Actually, last Friday I was in Battle Creek, Michigan, observing a training for 911 call takers. So that's really starting to happen. And I think part of the idea is just helping them like feel comfortable asking questions and then being able to figure out what information officers really need on scene. Because that's another thing I hear from officers sometimes is that, you know, we don't get the information that we need. So if we can make sure that those call takers and dispatchers, you know, ask the questions, but then also make sure they relay the stuff that's going to be really critical. And we're seeing more and more of that. The state of Illinois, our law enforcement training and standards boards is now putting out something for 911. So I think in the next few years, you're going to see a lot more of that. So,
following up on Dane County is now reviewing the relationship between mental health and the jail. We've had a study that showed about 40% of the people in the jail have mental health issues, which I think you touched on. You spoke about some crisis restoration, what we call crisis restoration centers, that were working well, and I think you said some that were kind of falling apart. And I wonder what you would think would be the key things to look for in trying to create a relationship between a police system and a crisis restoration center, or that kind of those kind of facilities within the community.
So something, I was at the National Council for Behavioral Health conference, actually also last week. There's a lot of places for spring break. But I went to a presentation. It was Margie Balfour, who runs the Crisis Triage Center in Tucson, Arizona. And I haven't actually visited it, and I've just read about it, but she talked about one of the things that they have is they don't deflect people that might be combative or violent. They don't make police stay. they are, I have no idea how they fund it, but they are appropriately staffed, so their mental health staff are able to handle people that many triage centers will deflect because they're not staffed to handle it safely. So that's one thing, and I think what they've seen is that when police officers learn that, they're more willing to bring people because they know that they're not just going to get deflected and that they're seeing something useful happening. So I think there's some models out there. There's not much in the literature at all about sort of like in terms of research on what's working better or not. But it's something, if police can actually make use of it. Chicago opened one, and first it was going to only be for police drop-offs. I'm like, well, can't people just walk in? And people can walk in now. They figured that one out. So, but there are some models that seem to be going well. And I know the one in Tucson, you can request money through the Council of State Governments, and they'll fund a team from your community to go see it. So, do we have? We have one more over here.
One more for Ed.
Oh, two more then. Sorry.
A couple anecdotes and a question. I lived in a building that I considered low income high density. And one night there was a gentleman sitting against the wall drinking a bottle of wine, gallon bottle of wine, a lot of wine. And I didn't have a background, so I called a social worker I knew, and he said, call the police, but make sure when you call them that you say you're worried about them. And that's why you're calling. And I did that, and when the police arrived, they started off saying, someone called because they were concerned about you. Are you okay? And another time, I lived in a building where people didn't know I had a support background, and someone knocked on my door and said, there's someone passed out on the sidewalk. What do we do? And I called the police, but I told them I called 911. I told them we need an ambulance. I don't think we need a squad car. They did send a squad car, but when the squad car got there, they were very respectful. They helped them up. They said, people were worried because you were laying down on the sidewalk, everything's okay. My question is how the police get to where they're going. It seems to me like it's really important how that happens as opposed to if you just call and say, I want this done.
That's a really good point. And that's something we can, people can think about when they call, but also how we train the people that are asking questions of the callers and how they relay that information. I think that's really an important point. And I haven't heard that before. That's a really good point. Thank you. Yeah.
I have a question about the new mayor of Chicago. I'm wondering, I don't know if you can answer this,
Okay.
but wondering how much priority she has put into services for people with severe mental illness and in support of the program that you've been working with.
So she has been involved in some work with NAMI Chicago, and for the accountability task force, she was supportive of the de-escalation work group that I was on that was working on the mental health piece. I'm not sure in terms of her professional history where she's touched on mental health services, but we're hopeful that she, and I believe her mother was actually a psychiatric nurse. Which is always good, go for that family connection somehow. So we're hopeful that she will pay attention. She's, has been critical, I know, of the closing of clinics. I know her opponent, Tony Preckwinkle, has done quite a bit at the county level in terms of supporting a triage center being open in that. So they were both strong, and I don't live in the city proper, so I didn't have to decide on who to vote for. But we're very hopeful that Lori Lightfoot will be supportive of that. And there's certainly people that have her ear that will push that.